All right, ladies and gentlemen, boys and girls. So sometimes it helps to be smart, but even better is to be lucky. And we are incredibly fortunate that in our region, we have this pediatrician who is an incredible champion for pediatricians, not just in her practice, not just in Northern Virginia, not just in our region and Pediatric Health Network, but the current president of the American Academy of Pediatrics. None of us knows how Sandy manages to wear all these hats and still be so smiling and happy. I don't get it. But we are thrilled to have Dr. Sandy Chung as our keynote presenter on caring for patients and pediatricians in a post-pandemic landscape. Current president of the American Academy of Pediatrics, Dr. Sandy Chung.
Thank you all so much. It's so much fun to speak at this conference. I know I've done that a few times before. I love the fact that you're eating while we're chatting because I get to be your entertainment. At my dinner table, which shouldn't be this way, but I have several teenagers and they're often not supposed to be on their phones, but they got their earbuds on. So I know they're on their phones and and they're often, I'm watching something or reading something. And so again, I'll be your entertainment for your meal today. Today, we're going to talk a little bit about caring for pediatricians and patients in this post-pandemic landscape. I am so honored to be here with you all. I think that the key, I don't have any disclosures other than the fact that I'm so appreciative of all of you and all that you do and who you are. But no other disclosures. Today, after the pandemic, we've had multiple issues exposed to us over the COVID years where we've identified things that are important in medicine and in pediatrics and what are things that we need to focus on going forward. But first, I wanted to tell you a little bit about me. Some of you may have already heard this story, but I am a child of immigrants. My parents came from China. My dad's dad, so my grandfather, actually had 5 wives, so he had a concubine. My grandmother was the 4th out of those 5 wives. And what that means in China is that the lower number wife you are, the lower status you have. And so my grandmother, being the 4th out of 5, did not have very high status. So my dad was expected to really maybe complete the 4th grade like his mother and then start to work in the family business in China. My dad, however, didn't really think that was what he wanted to do. He really believed strongly in education. And so as a child, he would go out to the streets of the village and stand beneath the street lamp to study. And he would do that every day, even though he knew if his father caught him, he would be beaten. He did very well. He went and got into high school. In China, you have to get into high school. And then he got into college. And then he and my mom immigrated to this country. So then I was born. I was born here, and unfortunately, because of the language barrier and the racism that existed when they moved to this country, they were unable to get professional jobs, despite both being college educated. So my dad actually was a waiter in a restaurant, and my mom sewed clothing in a factory. And then we were quite poor when I grew up. We lived in a trailer park. I was a Medicaid kid. I was on WIC. I still remember the big blocks of cheese that we used to get from WIC. I still love cheese. It's very much a part of my history. And then over time, they saved up enough money. And then eventually they were able to open up a Chinese restaurant. And this was in Richmond, Virginia. And so I actually grew up working in this Chinese restaurant. We actually basically lived there. We did have a house, but, my parents were working constantly. So I was just always there. And while I was there, I learned by osmosis, I think, about business and learning about how to run a business. And so learned, customer service, learned inventory management, learned how to, survive when the financial situation wasn't guaranteed. So all of that, I think, helped make me who I was, and as we know as pediatricians, what we experienced as a child basically defines our principles and values going forward. And so a lot of and the reason why I tell you all of this is that a lot of my upbringing really lends to what I hope to do and what I hope to bring to this role as AAP president this year. So let's talk a little bit about the changing healthcare landscape, because as we think about what to do going forward as pediatric businesses, as pediatricians providing services to families, what do we need to consider about the world that's changing? So let's first look at the population. So you can see before you the graphs that are from the US Census and from 2021. And it tells two very different stories. So the graph on the left is the age of what it looks like for kids, so under 18. And you can see here that 49% of children are consider themselves white. And then you can see there 26% of our childhood population actually is Hispanic. This varies by state, of course, to 2% in Vermont to upwards of over 60% in New Mexico. But on the right, you can see the adult population above age 60. And there, 73% of that population would identify as white. And when we think about who's making the decisions in healthcare and government, very much this is the population that's doing that. So as we're going forward, as we're thinking about what do we need to do to be ready for this next population, these are our patients today, the children that we're seeing on the left, but they're going to grow up to be adults, of course. And so with that comes different needs and different issues. So in order to be ready for what's coming, we need to have that available to us. It's true of my own family. So this is one of my nephews. His father is my brother, who's Chinese descent, and his mother is of European descent. And so he's cute, I know. And then he's here with one of my sons. I have 4 kids. So this is my second one, Alex. And so you can see that, if you think about how they're going to grow up in the world today, that my nephew may be able to experience some benefits simply due to the color of his skin and the lighter coloring of his hair, and for no other reason. And so really thinking about race as a social construct, it's not a proxy for biologic about biologic factors. And when we're considering medicine, AAP is focused very strongly on equity, diversity, and inclusion, and making sure that we do things like we eliminate race-based medicine. Race by itself does not determine your health, but it may be a proxy for something else, maybe where you live or your zip code or your income level. So again, taking race out of that picture. Now, of course, where they land in the future may not completely have to do with the way that they look. Their personalities may have a lot to do with that. And so there's more to a person than just the color of their skin, of course. This is also my family's friends. And so all of these children are half Asian. And so when we look at them, when we're giving them forms in our offices, which box are they going to check for us? We're all collecting data at this point, but I do think as we go forward, we really need to think about how are we going to collect this data for kids who are multicultural and ethnic. So Medicaid and CHIP, we've seen tremendous growth over the last few years in the enrollment of Medicaid. And you can see here that in the last 3 years that there's been so much growth that now 55% of children in the United States are now covered by Medicaid or CHIP. So over half of the children in our country are under Medicaid or CHIP. And that does vary state by state again, and by practice to practice, of course. But I think that is an important thing for us to recognize, that Medicaid is the largest child health payer in this country now. Now, why did this happen? There are several reasons. Obviously, over COVID, there were economic issues, right, that put families in income situations that made them qualify for Medicaid, or they were now eligible. But also over the pandemic, I don't know if you know, but there was the public health emergency, or PHE. There was a law, a requirement I don't know if it was a law, but a requirement that said states could not take anyone off of Medicaid during the PHE. So if they qualified for Medicaid during the PHE, they cannot be disenrolled. That also explains why there's continued increase. And here you can see the differences in enrollment for kids in Medicaid. And as you can see, there's some variability from state to state. So what do we do? What do we do in this landscape where we know that the world is becoming more ethnically diverse, perhaps in the United States, and that there are such a large population of kids that are now on Medicaid? And so there's good news. The government can work. I know there have been some issues recently, but it is possible for them to get work done. And so President Biden signed a really important omnibus package at the end of 2022. And I'm going to tell you a little bit about what was included in that as it relates to kids. So as you remember, I said that during the PHE that states were not allowed to disenroll kids or anyone that was on Medicaid. The omnibus package now includes a mandatory 12-month enrollment for all kids who qualify for Medicaid. That's huge. That's huge. If you think about the patients that you see, and if as their parents' income changes, they may qualify for Medicaid, then they won't, and then if they get a job, and then they may lose the job. And so, when you're on that line, if you're qualifying in and out of CHIP and Medicaid, that's really problematic. And then actually as providers receiving, the insurance cards, that makes an impact for us as well. And so that continuous enrollment is really impactful, just really for stability reasons, but also for access. If kids have insurance, then we're able to take care of them, right? And so also in the omnibus package was an option for states to also offer 12 months continuous enrollment for postpartum moms. It's not required, it's an option, but it is eligible. It is something that states can apply for if they wish. And then for CHIP, that's actually renewed roughly every 5 years. There was a 2-year extension so that now we don't have to reauthorize it until 2029. But I wanted to point something out. That's really exciting. 12 months continuous enrollment starting in January of 2024 is amazing. That's good news. However, the original issue where states could not disenroll people, right, during the PHE, originally was tied to the PHE. However, with the omnibus package, what they did is they pulled those things apart. So now there's a date. All of you may have heard of the unwinding. If you haven't, essentially the unwinding, that's what the term is for it. But essentially the concept is every state will now go through their entire Medicaid roster and re-enroll or check to see if people are still eligible based on all the requirements that were there before. And this is now, there's a date. It's not tied to the end of the PHE anymore. For a while, it was April 1st. So starting April 1st, every state in this country now can start going through their Medicaid rosters and disenroll people if they're no longer qualified. It does not mean it's a steep cliff. It's not like April 1st, people won't be enrolled anymore. That's not it at all. CMS has actually put in several guide rails over 18 months saying that states can start April 1st, and then over the next, they have up to 18 months to finish that unwinding. Now, what does that mean to us as practices? Well, obviously, if your families are being disenrolled from Medicaid when they thought they had Medicaid, that's going to be problematic. So states have been planning for this for quite some time because this is it was tied to the PHE. So they've been expecting this. What's different now is that there's a date when it's going to start. And so how can we be helpful here? There's a few different ways. So one is making sure that your families know about it, right? Where Medicaid families may or may not be aware that this is happening. And then the way that it's supposed to happen, and again, CMS is watching and regulating states and watching how they're doing this. And also there's funding available. So states don't have a really great reason to just drop people off, but it will happen gradually. It's that each plan, so a lot of our Medicaid patients are under MCOs, right, under managed care. Each plan is supposed to reach out to their enrollees and basically determine with each one of them, do they still qualify? If they don't qualify, they're supposed to help them with resources to find care, meaning a new plan. So if there's an exchange plan available, for example, if they now make too much money and they don't qualify for Medicaid anymore, then they should be given resources to say, hey, now you can go buy an exchange plan. So I think making sure that you're checking with your state Medicaid agency because each one has resources online on what you're supposed to be telling families. The concern, of course, is once they lose their enrollment, to make sure that they get something else in exchange. Right. That's going to be really, really important. And so one of our jobs is to, when patients come in and maybe they didn't have the right the address, maybe their address was out of date with the Medicaid. Their agency may have been trying to reach them, but they didn't see it, or maybe they didn't read it, or maybe they didn't understand it, all of that. Then we need, in our offices, need to be able to give them resources to say, here, this is what you need to do now. Right. So lots of resources from AAP coming for that as well. I'm just going to talk a little bit more about advocacy. We've all been living through the tridemic over these last few months, and hopefully it's starting to slow down, but it almost got a little too slow for some of us. I don't know. But I think understanding that AAP very much has been advocating, trying to figure out, what can we do better? What did we learn? What did we learn from the pandemic, first of all? But what did we learn from the tridemic? And we all know about the long waits in the emergency rooms, the overcrowding of hospitals, the overwhelming of our offices, lack of workforce, all the various things, the shortages of medications, all the things that we've been experiencing. AAP is quite aware of, and we have been working with the White House, FDA, CDC, and multiple state agencies to see what we can do to improve this so that we don't continue to have that issue going forward. COVID vaccines. So I wanted to touch on this as well. Have you all heard about commercialization of COVID vaccines? If so, raise your hand. Some of you, not everybody. Okay, this is important. So here, COVID vaccines, as we all know, we're getting for free at the moment. The funding for COVID vaccines and COVID testing, so all the free vaccines and the free testing that's been done, ended in 2022. So there's no additional federal funds to continue to buy COVID vaccines and testing. There were purchases that happened already for 2023. So that's why we're still getting it for free. However, there's no additional funding. There's no plans for that, and there may not be any political willpower to do that. What that means, though, is that COVID vaccines then need to become commercialized. So it will turn into just like any other vaccine that we give. So lots of issues there, right? And so we have met with the White House multiple times. We have continued to advocate with the manufacturers and the payers and all the people who are involved in that whole process, because as we know, as pediatricians, there's a significant piece of operational work that has to happen there. Because if you are wasting COVID vaccine today, which is likely, if you had to pay for that as a practice, right? That's huge. So you may be getting some single dose vials now. You may be getting 2-dose vials from Moderna. That is from advocacy from lots of people, but including AAP, to say so we can't, it's not viable, right? Getting 10-dose vials, throwing away 8 when you paid $100 for each dose is not going to work for all of us. Also, that initial purchase is a problem. Right. I don't know about you, but if you have $100,000 sitting around to buy some doses, that would buy you 1,000 doses, I guess. That's a problem. The pricing's also a problem. Moderna recently released at their price what they think they're going to be charging, which is about $105, I believe. And there's no particular reason for that. So advocacy is going to have to happen there as well. Also, VFC. And understanding that impact on VFC. My freezer in my office has, I think, 8 different versions of COVID vaccines right now. And so if you had to have a second stockpile for VFC as well, that's problematic. So I think what my message here is that there's a lot of advocacy to be done in order to make this viable. They have heard us loud and clear. Hopefully it will happen before it actually is implemented. Coding, right? Making sure the payers load their fees, all of those things in advance so that we can make this smoother. Happy to continue to hear from you all as well. So please make sure if you reach out to me as you come up with thoughts about that. So let's talk about advancing peds. One thing the pandemic has done is it's also spurred innovation, and spurred how we do business differently. Telehealth is a great example of that. We've talked some about data today. I think one thing I wanted to just point out is AAP has become a data expert for the country, which has been interesting. In pediatric vaccines, COVID vaccine rates, COVID hospitalization rates, all of that, AAP was not previously a data house, if you will. We had data, of course, but during the pandemic, we took on that role because nobody else was. And so we took on that role, and now there are organizations like CDC who look to us for data and look to us for the questions on how the health of children is in our country. And so the child registry, which you may have heard of, is something AAP has been working hard at. And the idea is so that we can truly represent how the data for children and what's going on. Reducing barriers to care, again, telehealth has done a lot of that, and we have all at least dabbled in it and perhaps embraced it in some cases. So now we also need to think about how we're using it and looking at equity and disparities. So AAP has several task forces that have been formed to look at this and to really study the impact of telehealth on children. Payment models. Now, you all who know me know that I run a group called Trusted Doctors, and I've spent my career in the business of pediatrics. And so, not this conference necessarily, but in the business of pediatrics in my day-to-day work. And so that is something that I'm very passionate about, and it's something that I bring to this role. As we know, we've talked a lot about value-based care, and it is not designed for pediatricians, and you really can't say that you value children if you don't also value their doctors. And so thinking about how do we redesign value-based care so that it's appropriate for pediatrics, understanding that a lot of payers think of short-term, how do I save money in 12 months? For us, we know when we save money, when we're taking better care of a child, that child is staying in school, not going to jail, becoming an adult that's employed. All of those things that we do to make sure that our future generation is healthy needs to be rewarded and needs to be recognized. So again, looking at how do we do that? So there's work to be done in that space. I did want to point out that the United States spends less on primary care than any other industrialized nation. So about 5 to 7% of the healthcare spend is on primary care. Other countries are spending upwards of 10% on primary care. So it varies by country, of course. But the message is that primary care needs more support. And we saw that over the pandemic. The pandemic, when we had visit volumes go down, we know that our payment model is not sustainable for pediatricians, and that what we do is an investment in the future. This here, if you've not seen it before, is the Heckman curve, the one on the right. And what this is really designed in looking at early childhood education. And when you do interventions early, the payoff is tremendous over a lifetime. The other thing to recognize is the team has gotten bigger. I remember when we were talking about, just adding advice nurses and triage services to our practices, and then now behavioral health. But if we really look at the whole ecosystem of where a child is, it's a much bigger place when we're looking at child health. But there's no way that we're going to be able to do all of these things in this current payment model. And so, but we need to. And how do we support pediatricians so that we can do this work? So we know that value-based payment needs to address things like childhood adversity, social determinants of health, looking at medical complexity, but also look at parental complexity. Right? A child does not exist in a silo. A child is in a family unit of some sort. And so really thinking about how do we address that as a whole. And providing risk algorithms. This is getting a little bit into the weeds, but in our value-based care programs, our children are rated based on risk, and the risk algorithm is based on adults. And so all children look healthy compared to an adult. In fact, when they figure out the risk algorithm, they assign the number 1.0 to a healthy adult, and children are compared to that. And sick adults are compared to that. And so children are going to be less. Why does that matter? Well, all the formulas that determine how much you get paid in these value-based programs are multiplied against that number. And so it's no wonder we're already getting less than the adult medicine practices when their healthy adult is a 1.0 and our healthy child is a 0.7 or 0.8. It's already a reduction straight up front. Payment for telehealth, of course, and continuing the ability to do telehealth across state lines and things like that. So AAP is doing a lot. So we've already been working at it. They've kicked into gear, and I just wanted to update you a little bit on what's happening. So several policies are being published or already have been published on this that had not been the case for many years. And so now we have put out 2 or 3 very rapidly. And in AAP policy times, that's actually pretty fast. There are some that take several years to accomplish. And so we're really excited that we have policies in place. And the policies matter because this is what we go to the Hill with. This is what we go to payers with when we have a policy that we can point to. We've been engaging payers, having conversations at a national level already to talk about why children are important and the special value proposition that we bring. And then we're convening a Medicaid summit of stakeholders who are expert and leaders in this field this spring. Dr. Russ Libby, some of you may know him. He's from Northern Virginia. He gave a very generous grant to establish a fellowship on pediatric payment and pediatric practice and payment transformation. So we're really grateful to him. Ellie Sprecher here, who was trained at Harvard and is at Boston Children's, is our first fellow, and he's spending his time really working on this. So the focus on looking at value-based care for pediatrics, finding models that work, and then helping to drive this work going forward. Wanted to touch a little bit also on mental health. As we know, we're all working in the mental health space every day. And suicidality is the second leading cause of death for kids ages 10 to 24. If you were to look at the year 2020 and the number of kids that died from suicide and put them on airplanes, this is what it would look like. When one airplane crashes in the world, it makes headlines. And so if 6 airplanes were crashing every year and growing, it should make bigger headlines, and we should fix it. Actually, suicide has more of an impact and is a leading cause of death in kids. If you were to take the next 10 medical reasons why children die, there are more kids who die from suicide. If you were, so just really thinking about how much that would be. If we had a disease, if we had a weird new disease that killed kids to that impact compared to our other diseases, you can bet we would be investing in that, and we would be trying to solve that problem. So the AAP, the Children's Hospital Association, and the American Academy of Child and Adolescent Psychiatrists declared a mental health emergency in October of 2021, and we renewed it in 2022. And this has been hugely impactful for getting legislation done. We have a new initiative at AAP called Upraising Healthy Children, where we're working on building collaboratives across multiple stakeholders who work in mental health. This is a really big initiative for pediatrics and AAP. And I think this is really important. We talk often about resilience, but instead of having the children fix themselves, can we fix the world around them instead? So this is one of the concerns, right? So online usage, there's a lot of news about that now, but there's a lot of concerted effort on looking at how do we protect children against the digital technology space that exists today. So obviously in social media, there's that issue. This generation right now will never know what it's like to not have the internet. This generation will never know what it does. They are so used to having the whole world of information at their fingertips. They will never understand that world was different. And so knowing that, what do we need to do to protect them and to keep them safe? And then also to make sure that new things that are rolled out that we don't even know about today have guide rails around that for kids. So we are starting an excellence center. So we were fortunate to receive a grant for social media and youth mental health. And we will be studying this. We'll be doing research, which is important. And then also to look at the impact of social media and then working on advocacy as well. We've partnered with YouTube and put out several videos for kids and for parents on what they can do if they're feeling, if they're worried about themselves or a friend, ask a friend. So this really great series of YouTube videos, and we're putting out more and more of those. Advocacy, that's always the strength of AAP. And I'm pleased to say that we are getting somewhere. So things are happening. The mental health access programs, as some of you may know, I'm passionate about. So the VMAP, BHIP, DCMAP, all of those, they are now in nearly every state in the United States, every territory as well. We not only got funding for them, but we got more funding than we actually asked for, which never happens. That never happens. But that gives you an idea of how impactful what we're doing is. The 988 suicide line, how many of you heard of that? Yeah, so it's very much like 911 just for mental health concerns. So any of your families, anybody, parents can call. I was talking to one state director of their 988 line, and they've had calls down about kids down to age 5. And he told me a story about how this call center folks who are trained to answer crisis lines they needed an algorithm for what to do when the person on the other end didn't say anything. And what I mean by that is people would just call just to hear somebody else's voice. And it was just amazing. And so the people who were answering the call line said, you can say, I know you don't feel like talking right now. Sometimes it's just better to hear another person's voice, but just want you to know that I'm here for you. And if that didn't exist before, I mean, really, just think about that. That's so incredible that we have such a thing. So there is space for improvement. There's so much we can do, and there's a lot happening. That's the good news. Safety and well-being, of course, this is a top priority for AAP. And unlike ever before, we are being faced with security questions, how to de-escalate people, all of these things that we've never had to necessarily deal with before. How do we stay safe? And so we've partnered with AMA and the Children's Hospital Association. We wrote to the Department of Justice to say, we can't let this happen. We need to investigate. We need to make sure that people who are doing this know they're not allowed to do that. That is not okay. Knowing that we are doing work every day that might be more challenging than ear infections and strep throat. How often are you going through your day and you're like, oh, good, sore throat, got that one. So I can catch up on my last 3 notes maybe. Go swab that kid. Let me finish this note. So the work that we're doing is harder, and and we need to recognize that when we're doing this work that we may feel effects from it. Have you ever heard of compassion fatigue? Can we raise your hand if you've heard of that? So compassion fatigue typically was in the realm of caregivers, so nursing, home health, different places where we were caregivers. But really, compassion fatigue is something that we may be suffering from. Some of us. There's burnout, but this is not burnout. So compassion fatigue is when you're taking care of people all the time. And you're taking care of people, and that having that care that you're giving, and you may be caring for someone at home. There may be something else going in your life where you're taking care of someone, and so there's multiple impacts to us. There's cognitive, emotional, behavioral, and physical. You may be feeling, tired. You may not be sleeping well. There may be apathy. Apathy is an interesting one. So if you now have patients where you don't even bother talking about the COVID vaccine because you just don't want to talk about that. That may be some compassion fatigue. So making sure that you recognize that you do need to take care of yourself. It is not the space that we're in is not our fault, right? The response that you're having is completely normal. The problem that we're having potentially is the system that we're operating in. The Atlantic Journal, they said it nicely. They said healthcare workers aren't leaving our field because we don't want to do our jobs. We're leaving the field because we're tired of not being able to do what we need to do our jobs. So as we're going through our days, though, maybe we do need to think a little bit about what we are doing well. There's a lot that we're doing well. And so instead of perhaps thinking about in your 18 patients, that one patient that was really hard, think about the other 17 who were grateful for you and grateful for what you did for their child today. I think vicarious resilience is an important concept. There's vicarious trauma, where if you are taking care of someone who's been through a trauma, you may feel symptoms of that trauma, but there's also something called vicarious resilience. So I don't know about you all, but when I went through my PICU rotation, I remember seeing a child who had cardiac surgery, complex cardiac surgery one day. And then 2 days later was sitting up in bed, playing, smiling, had all these things, but was a happy kid, and so kids are so resilient, and we can actually learn quite a bit from them. We can absorb some of that resilience. I think understanding their perspective of, how fortunate we may be in what we do and the impact that we have on families, and remembering that as we go through. I like sitting in my office where I can hear people opening the doors, down the hall, where you can hear people going, "Hey, how are you today?" We are so good at acting, though, and so you may be having a horrible day, but you're going to walk into that room happy. And so, and we're going to get down on the floor and be like, "Oh, how are you doing?" I haven't peed in 4 hours, but so I don't know if I'm allowed. I'm among friends. So sorry, this is being recorded too. But anyhow, it's true. And so, so I think remembering the good parts of our day and recognizing that we just have just such an amazing opportunity to take care of people and to impact the entire future of our country, taking charge of how we think about ourselves in our day. It might feel like this sometimes. It might feel like this sometimes. Sometimes it's kind of like this too. A lot of times it feels kind of like that, right? Like what? But reframing what we see every day, reimagine what we could do, and then making sure we do what we can to rejuvenate. So important. And you never know who's going to, it is me, so you never know what's going to happen with the child in front of you. And so thank you all so much for the opportunity to speak to you today. I appreciate it.